Well, I'll introduce you, Dr. Phillips.
Okay, great.
All right. So, all right. I think most everybody is back in the room, so I'm going to go ahead and introduce you. I'm sorry, Dr. Phillips. I'm a fan, so I could spend the whole hour on your introduction, but I'm just going to hit the highlights because I think most everyone in this audience is familiar with you, or if they're not, then they know your work and just haven't put it together. But after earning her medical degree from University of Alberta, Dr. Phillips completed her training in internal medicine, infectious disease, medical microbiology, clinical pharmacology, and then completed a research fellowship in immunology and drug safety at the University of Toronto. She's professor of medicine, pharmacology, pathology, microbiology, and immunology, and dermatology at Vanderbilt, where she's the founder and director for the Center for Drug Safety and Immunology, and she serves as the John A. Oates Chair in Clinical Research. Her research integrates HLA-associated risk prediction, T-cell immunology, and clinical implementation of this science directly influencing guidelines and improving patient safety on a global scale. She has helped to advance prevention, diagnosis, and treatment of severe adverse drug reactions by bridging dermatology, immunology, and infectious disease research. She is internationally recognized for her transformative contributions to drug and vaccine safety, with over 450 peer-reviewed articles, including just a part of which is her pioneering work in identifying the genetic markers that prevent life-threatening drug hypersensitivity reactions. And that includes work that helped to establish into clinical practice the routine screening for HLA-B5701 prior to Abacavir prescription. Her work has involved developing strategies to delabel low-risk antibiotic allergies and advancing our mechanistic understanding of the severe cutaneous adverse reactions, including SJS-TEN and DIHS-DRESS. She directs multiple NIH-funded consortia. She's established one of the world's largest SCAR biorepositories, and she's mentored numerous physician scientists. And in recognition of her impact, she was elected to the Association of American Physicians in 2023 and the American Association for the Advancement of Science in 2024. That's the brief version, Dr. Phillips. Please join me in welcoming Dr. Phillips this morning.
Well, thanks so much. That was such a kind introduction, and it's really a pleasure to be here virtually to speak to you all on this topic. And I will spend, I think, some extra time on some of the areas that I've been interested in terms of research. I don't have any conflicts related to this presentation. And what I'd like to do is give you a bit of a roadmap of sorts in understanding some of the classification of these severe cutaneous reactions, go into some detail about risks, genetic risks and mechanisms, and then talk about some of the diagnostic issues that we deal with in the allergy and immunology clinic, I think more in the US than dermatology, but just out of interest. And then those lead to identification of the culprit drug, which ends up being one of the most common questions that we get asked. And then future directions, what can we look forward to in terms of some of the work we just heard about in suites, and how is this applying to SCAR? And so I'm going to start with a case, and this is a 65-year-old white female, infected knee prosthesis, polymicrobial, and this is a common scenario. She started on multiple antibiotics at the same time, and 3.5 weeks into all of these, she develops facial edema, lymphadenopathy, fever, rash, eosinophilia, and hepatitis. And some of the questions to consider as I'm going through the presentation: what is the clinical diagnosis? Is there a likely culprit drug? And if so, what would it be? And what are the considerations about managing this woman, including future drug safety? And would there have been a role of genetics in prediction, prevention, or diagnosis of this reaction? And so I'm going to start off with definitions, classification, and recognition. And what about the dermatologist's role in SCAR, and why is it so important? Well, dermatologists clearly are used to taking care of complex patients with multiple and multi-system cutaneous diseases, and they're used to using the drugs that are used to treat these kind of diseases, which are having a role in scars, we increasingly understand, but are less familiar with using multiple diagnostic techniques and methods to identify culprit drug. And I will spend some time on that. And so what are these scar reactions? As you all know, these are drug reaction with eosinophilia systemic symptoms, sometimes called drug-induced hypersensitivity syndrome from the Japanese classification, Stevens-Johnson syndrome, toxic epidermal necrolysis, increasingly just called epidermal necrolysis, acute generalized exanthematous pustulosis, and then last but not least, generalized bullous fixed drug eruption. And so I just wanted to put a construct on to give you somewhat of an idea of how these T-cell mediated reactions of the severest spectrum fit into ADRs overall. And clearly we have side effects on one side of the spectrum. And then we have some more immediate or antibody-mediated reactions. We have non-immune-mediated cellular toxicities. But in terms of the T-cell mediated reactions, these tend to be, when they're more severe, they tend to be lifelong and a stop sign to avoid these. And many of these also are HLA restricted, as I'll get into. So this is a montage, if you will, of scar cases. These scars differ in terms of how common they are, and SJS and AJAP are actually the least common. DRESS is probably more common than we realize, and when the drug is stopped, in many cases, things don't progress. And you can see generalized bullous fixed drug eruption has a very distinct presentation, and this montage is really illustrating how these different phenotypes present on different skin tones and pigmentations. And I think you can also see just in this miniature rash representation that the rash of DRESS has a very polymorphic presentation. It can be anywhere from erythema multiforme-like to purpuric, which has a worse prognosis, to a simple morbilliform drug eruption that would be indistinguishable from just a benign rash. The time course is one of the things that I emphasize the most, because this really is super important, because these major scars are distinguished by their latency. And so fixed drug eruption and generalized bullous fixed drug eruption is really quick. So it occurs within hours often, and AJAP can occur within the first few days. But SJS and DRESS are longer, with DRESS having the longest latency, and there is something called what we would call a short latency DRESS that is often associated with antibiotics like beta-lactam antibiotics. If we look at scar comparisons, as I mentioned, these differ in terms of their latency, but also in terms of their mortality, with SJS-TN still having the highest mortality. However, when generalized bullous fixed drug eruption affects a high body surface area, especially in elderly patients, it can also have similar mortalities to SJS. And the ones that we know to be HLA associated currently are the DRESS and SJS, most likely, although we suspect that the others do have some associations. They just haven't been uncovered yet. DRESS is the one that has relapse, viral activation, and autoimmune sequelae, whereas SJS, the major long-term morbidity, are some internal organ from strictures, reproductive, and eye. So what about the risks and mechanisms? And when we look at the etiology and the mechanisms of these reactions, these are all T-cell mediated reactions, and they result from T-cell activation from various mechanisms that I won't go into. But the most important thing to realize is that signal 1 of the T-cell activation is just part of the story, and signal 2 is what really completes the activation and determines whether you're going to see drug antigen-specific T-cell proliferation and homing in many cases, like for DRESS, AJAP, and not so much SJS, where we think resident T cells are prominent, but they home to different organs, including the skin and internal organs in this case. And these reactions all differ in terms of these homing features, in terms of the T cells involved, in terms of the cytokine influences. And this is what is thought to lead to the differing clinical presentations. Now, just to get into the genetics a bit, our immune system has evolved clearly over millions of years, and drugs have been late introductions to life, really. And so drugs have served as infections of humankind, where we saw some of the first allergic reactions very early in the piece, but drug allergies appeared late, and these include many that I won't talk about, like serum sickness reactions and some of the earlier reactions, but the T cell mediated reactions really became prescient with the advent of the drugs that we still use today, like the sulfonamide antibiotics and the anti-seizure, aromatic amine anti-seizure medications. And so, as I'd already mentioned, it's mainly DRESS and SJS that we know today are HLA associated, and then organ-specific diseases like drug-induced liver injury also are. If we look at the presentation across different HLA alleles, this was until recently very much a story of HLA-B, but it is very much a story of HLA class 1 or A, B, and C alleles. And as time has gone on, we found that there are many different HLA associations that define different drugs, but also that there are associations, again, with HLA-A, prominent associations actually, as well as HLA-C. And for some drugs, they have associations, as you'll see, across all of these. And so a lot of this mainly has to do, in the case of drug reactions, which have come to the piece late, with probable co-evolution with infections that have actually, the reactions with drugs have ended up being immune mistakes, where we think that the prominent mechanism here is that there's a cross-reactive memory T cell response mediated by the same class 1 HLA, so a double hit hypothesis, and that basically later in life when you take a drug, that immune mistake occurs when the drug alters a self protein, and that mimics the reaction, the immune reaction to a virotope that's occurred decades earlier. And we think the prime viritopes, the prime viruses that are actually involved here are the chronic prevalent viruses that you see a lot of in dermatology, such as the human herpes viruses. One common and prominent issue is that the common drugs with SCAR have not changed over many decades, and you're all familiar with what these are, but this obviously opens up a pathway for prediction and prevention. And so I just wanted to give you a bit of a global scheme of HLA and how different HLA alleles are represented in different geographies. And so it's important to remember when we're talking about HLA risk that the HLA composition of countries in Southeast Asia is totally different from that in the United States. And this, of course, significantly drives which risk alleles are likely to be involved with which drugs, and even the prevalence of those that are associated with drugs. And if we dive in right in the middle in India here, we can see that India actually has representation of most of the HLA alleles that are seen globally. And India has the highest prevalence of severe cutaneous adverse reactions in the world. And so not surprisingly, when all of the major risk alleles are represented there. And so this is extremely interesting, and I'll go into some of the nuances regarding this and how it relates to United States in a minute. But the HLA associations with drugs, this is how things have evolved over the last couple of decades, with the Sentinel drug that was associated with a hypersensitivity syndrome, which was one of the first 4-digit HLA associations once it was possible to actually do HLA sequencing, not just by serotyping or antibody, was abacavir, and this was an HIV drug. And it turned out that this was a European allele, B5701, and that a high proportion of people that had this actually got abacavir hypersensitivity. And this was really crucial to the rollout and the implementation of this, because it meant such a small number were able to be tested to prevent one case that even individual practitioners could see the impact of that immediately. And you can imagine the challenge that if you're seeing a few cases of DRESS and a few cases of SJS/TN here or there, not only when you actually see the cases, they've already occurred, and so you're thinking less about prediction, maybe about future risk stratification, but the ability to actually see the impact of screening before your eyes after implementing this after a few weeks was pretty incredible in this era. And so the other major point I'll make is that although the same HLA alleles are often associated with both DRESS and SJS, and this is curious because we don't understand why in the same patient, they will go to either DRESS or SJS, but they will go to one or the other, for instance, allopurinol and 5801. But for other drugs, there's the HLA association is only associated with a single phenotype and not the other phenotypes. We don't understand this. There's a great deal to be learned mechanistically from this, but we do understand things like, for instance, with carbamazepine restricted by HLA-B 1502, that there appears to be a public T cell receptor alpha beta clonotype that is found and is shared among individuals that have carbamazepine SJS. And this is not the same for any of these other phenotypes that we've found. And I'll show you some of our single cell work in a minute. And so there are gaps when it comes to thinking about using genetics for screening primarily, and the gaps are positive and negative predictive value. And the reasons for this is that the positive predictive value in particular affects the number needed to test to prevent one case, which impacts the feasibility. But, and you can see some examples of this when you go for different types of drug hypersensitivity reactions. That abacavir had the highest positive predictive value, was the ideal one to get into screening first. But these differ significantly. So most of them are more like allopurinol, and only about 3 to 8% of those carrying a risk allele will develop a hypersensitivity syndrome with allopurinol, either DRESS or SJS, and then vancomycin is somewhat in between. And so what about the risk of the negative predictive value? And this is something I think that goes a little bit less noticed, that most HLA risk alleles do not have 100% negative predictive value. So that simply means, you know, if you're starting someone on, say, trimethoprim sulfa for acne, and there's been an association between B1301 in Southeast Asia, that you would have to know that that finding is generalizable to the United States, because in fact, as I'll show you, it is actually not. So HLA alleles are geographically distributed, and in order to actually predict everyone at risk, you would have to know the distribution of those alleles, and you would have to have studied the risk across heavily admixed populations. And this is, of course, crucial because the United States is a heavily admixed population. I just wanted to say a couple of things about abacavir and its implementation, and I've already said this, that this was really one of the first drugs for which there was level 1A evidence to support screening prior to prescription, and it was successful because only 13 patients needed to be tested to prevent a single immune confirmed case, which in the clinical trial was abacavir patch testing. And really, this was really striking because HIV providers could tell within weeks of implementing this screening, and sometimes sooner than that if they had practices in the 2,000 to 3,000 range, that this was working, and they just were no longer seeing abacavir hypersensitivity. And I'd bet that not many people in the Zoom room have actually seen a case of abacavir hypersensitivity, and that's an extremely positive thing. So this is a case study that we saw a couple of years ago, who was a young man who developed SJS associated with trimethoprim sulfamethoxazole. It was the primary culprit. There wasn't much doubt about this. He'd had a skin and soft tissue infection, and it started 6 to 7 days later, which is quite common for this to be quick with antibiotics. And you can see the evolution of his disease through reepithelialization and complete healing. But what I'm going to say about trimethoprim sulfamethoxazole is there have been strong HLA associations with it, and these were initially described in Southeast Asia. And this is a meta-analysis that was done following the original description of the HLA associations, which were primarily HLA-B1301 and HLA-B3802, and then a couple additional ones that seem to be more common in HIV positives, the B1502 and C0801. But when we looked at this in the United States, what we found is something quite different. We did something called the SJS Survivor Study, where we actually recruited patients from the community with Stevens-Johnson syndrome. Then we had dermatologists adjudicate their charts in a blinded fashion from the records that were sent in. And we've analyzed this now for the most common drugs associated with SJS in the United States. And this is the cotrimoxazole data that I'm showing you now. But really what was striking about this is the HLA-B1301 allele that was commonly associated with SCAR in Asia was not associated with SJS/TN in the United States. In fact, we only had a single case. And the other very interesting thing was that the HLA-B3802 allele that was associated in Southeast Asia was not seen in the United States, but 3801, which is closely related to 3802, was. And when we looked at these using a heat map approach that actually looks at shared peptide binding specificities between these different HLA alleles, we found that there was actually a commonality between these HLA alleles, that although they were different and they typed different at the 4 different digit level, and they were distinct alleles that wouldn't be picked up by single allele typing as being the same, that we could see that they shared peptide binding. So they like to bind the same peptides, and presumably this means that they would actually make a similar immune response if a patient actually with one of these alleles was exposed to Bactrim. And so this was data that we've recently published, and this is a model that we think will be applicable to many drugs in the United States, with lamotrigine rather being a prominent cause of SJS and DRESS in the United States. This will be the next one that we will publish. I'm not showing you data from that today. And so this young man ended up having B4402, which is actually one of the B4403 peptide binding groups. It's related to the original allele that was described in Southeast Asia, the B1301. So he had this, and we suspect this is his risk allele. And based on this, we have constructed a global map of trimethoprim sulfamethoxazole SCAR in different areas. And you can see that in the United States, Europe, and even South Africa, we did have South African cases, and we published this as part of the Gibson et al. Publication below, that they had a different pattern than that seen in Southeast Asia. So just this is a negative predictive value caveat that we need to look at multiple alleles together in a panel in heavily admixed populations. And this is another story that is evolving, I think, to be quite important. And so we were prospectively enrolling patients with SCAR, with allopurinol SCAR, into our cohort study for the last 10 years. It took a long time because although these are not uncommon across the United States, trying to get data from one center is also pretty challenging. And so we identified 16 cases, and 11 of those 16 were US Black individuals. But when we analyzed the HLA data, we found that only 45% of the US Black individuals did not have HLA-B5801, which is the primary allele that's associated with allopurinol SCAR in Southeast Asia. And we found in a conditional logistic regression analysis that was controlled for multiple comparisons, that HLA-A3402 was a prominent associated allele outside of HLA-B5801 in our population. And fascinatingly, when we went back to the literature and we found an old paper published in the British Journal of Dermatology, we found that unbeknownst to the authors at the time, but 5 out of 7 that didn't have 5801 in this Portuguese study actually also carried A34. So we think this was actually discovered before our study, but the authors didn't realize it at the time. And we think this is actually going to be something that is to contend with, given it's interesting that HLA-B5801 is carried 4 times more frequently in US blacks than US whites, and yet there's still 45% of them don't carry 5801 when they develop allopurinol scar. And this is just a collection of our cases. Interestingly, we also had one patient who had B5802 positive allopurinol SJS/TN, which is closely related to HLA B5801. And so I'm just going to change gears a little bit, go into sort of the field where I see a lot of patients clinically talking about diagnosis, identification of the culprit drug, and management. And this is just to illustrate that I can't emphasize enough how important it is to draw out the timeline, because if you don't, and this happens, patients don't sometimes draw out their own timeline. So they come in like this woman saying, I've taken amoxicillin, ibuprofen, and I've now got this terrible rash. But really, the cause of the terrible rash was the lamotrigine that was started, a couple of weeks prior. And it's so important to look at timelines to rule out protopathic effects. So amoxicillin and ibuprofen could very well be protopathically linked to the SJS/TN here, but they're not the actual cause. And so we use skin testing in our clinic from a number of reasons, but skin testing really vary, and delayed intradermal and patch I will collectively call skin testing, but they really differ in terms of how well they perform, both on a drug level and on a phenotype level. And so they have a very poor performance for SJS/TN. So we're not so worried we're going to reproduce SJS, but when we actually try and test patients with SJS to drug, maybe outside of some aromatic amine anticonvulsants, we don't see positive results. So the false negative rate is really high, so we can't use it very well in SJS/TN. But for DRESS and morbilliform drug eruption, or even in situ application to a fixed drug eruption, there's actually a better sensitivity, with DRESS having the highest sensitivity of the scar. And this was just one study that was done that was a systematic review that really just shows you how the performance of skin testing varies across different drugs in relation to DRESS. And we can't really use it for sulfa antibiotics at all, because it just seems to have zero sensitivity. For allopurinol, it's like zero sensitivity. But for beta-lactams and other antibiotics, it's quite good. For radio contrast dye, it's quite good. And for anti-seizure drugs, it's quite good. And so helpful if it's positive. I should say helpful if it's positive. If it's negative, then you still have to be cautious that you could have a false negative. And this is just to show that the skin test responses that we see in our patients are durable. So this man had a picture of his face from 2013, and the rash and clinical history fit with acute vancomycin DRESS. And when we did HLA typing, and we've got a single allele assay that turns around in 2 to 3 hours in our lab, we found he was A3201 positive, which is a risk allele for vancomycin DRESS. And then we did his skin testing, which remarkably, even 8 years later, was still positive. And you can see kind of this blistering look to the skin. It doesn't go much further than the skin test, but these T cell reactions in the skin, they create like quite an exuberant response, which mimics the rash histopathologically of the acute reaction. If we were to take a biopsy of this, it would have some features very much like DRESS, the spongiotic dermatitis with infiltration of eos and lymphocytes. But this is the skin test with the drug applied intradermally now 8 years later. And interestingly, for some phenotypes, the mimicry of the phenotype can happen in the skin. So this is a woman who had AGEP in 2013. Intriguingly, this was also vancomycin, and she also carried the risk allele. But when we actually tested her, we reproduced the AGEP reaction in her skin, and you can see this is actually sort of a classic depiction of AGEP, but it's due to the skin test, not due to taking the drug systemically. And when we did this in a more controlled fashion on her back, because we knew that she would do this, interestingly, when we tested her in the flexural part of her arms, and this was simply because we were testing so many antibiotics that ended up being negative, which opened up therapeutic, options for her. But we did this on the back later because she ended up having multiple episodes, including after COVID. And we wanted to see if she was still making the same response to vancomycin, which she is. And this is the histopathology from that skin test in 2021 that shows subcorneal pustules and a histopath picture indistinguishable from AGEP in the skin test. So I'm going to come back to our case study now. This was our woman who developed a rash on multiple antibiotics along with systemic features. And the question is, what is the diagnosis here? And so this was a case, as you might guess, of antibiotic-associated DRESS. But the problem here is she was started on 3 antibiotics at the same time, which complicates things. If you calculated her Regiscar score, which is just a scoring system you're probably all familiar with, where you actually add up different clinical features, exclusion of other lab features, and histopath compatible, et cetera. And hers was high. It was probable DRESS. And then we did her clinical assessment, which would have indicated that in the United States today, vancomycin would be the most common cause, especially with this timeline. But she was HLA-A3201 negative. So what then? So we went on to do something called a gamma interferon ELISpot, and we found that she was also negative to vancomycin on this ELISpot, but intriguingly, she was positive to rifampin. So we think that this was a case of rifampin DRESS. And so this just gives you a flavor, I guess, of how we can use integrated approaches to try and figure out the culprit drug in multiple when multiple drugs are involved, such as multiple antibiotics. We've done a lot of work with vancomycin DRESS since the discovery in 2019, and think this will be a test that actually does play a role in diagnosis or preemption, and probably less so unless we start doing it on everyone in the population, and we don't want to use that much vancomycin. So probably the preemption is actually intriguing because it takes a median of about 22 days for vancomycin DRESS to occur. So you've got a window to start someone on vancomycin, do their genotyping, and actually risk stratify them before they would show any signs or symptoms of DRESS. And this is just some of the ex vivo testing. These are useful, and we do this in our lab, although we don't use it for clinical purposes. It's used for research purposes. But the problem is the lack of sensitivity that all of these ex vivo tests have. And we think for some phenotypes that the cells mediating the reaction, these T cells, after about 3 months or so, these are extremely rare in the peripheral blood. And I'll show you some data on that. And therefore, trying to get any sort of response out to ascertain drug causality in the peripheral blood is challenging for SJS. I'm just going to say a couple of words about what is happening in lower and middle income countries, which I think is very exciting, that they have a lot of tuberculosis and HIV, TB co-infection. And so they have actually started to do something the last few years called sequential additive rechallenge, which to identify the culprit drug. And in patients that have DRESS and SJS, most typically, they see a few cases of generalized bullous fixed drug eruption, interestingly, very few cases of AGEP, but they have taken to actually re-challenging these patients sequentially to the anti-tuberculous drugs and then rescuing them as soon as they see the first sign of a reaction with steroids. And this has led now to completion of first-line treatment for tuberculosis in a high number of patients. So it suggests if you observe patients and you get them early enough, you can abort scar reactions. This is clearly not something that we're doing in the United States. And they've now published this same work with DRESS, which interestingly, the DRESS data is interesting. It's a highly effective way of getting patients on first-line tuberculous drugs. But it's interesting because about a third of patients who actually had reactions to rifampin also had reactions to ethambutol, suggesting that there is an element of multiple drug hypersensitivity as well. And this is just this data. And so this just gives you a scope of using integrated approaches to the care of patients. This is something I think will become routine in the future. It's hard to put all the pieces together now in terms of the specialists needed and the specialty lab services to make this happen. In terms of treatment, I think what is clear across all SCAR is that evidence-based approaches, high-level evidence-based approaches are missing, but there is a high degree of overlap between drugs that we use. For DRESS, systemic corticosteroids are still the mainstay, although there's many other drugs that actually are intriguing. And I think DRESS has many different subphenotypes, right? So it would also be very interesting to know what works best in different endotypes of DRESS. For SJS/TN, there's one small randomized study that was open that actually favored TNF-alpha antagonists, but it was small. It was done in Asia, and so the generalizability of the data is not really known. And cyclosporins and JAK inhibitors also show promise, both for JAK inhibitors and cyclosporins also in DRESS. For AGEP, we usually just stop the drug and use topical corticosteroids, and sometimes generalized bullous fixed drug eruption is severe and commands systemic corticosteroids. And so I just wanted to put a couple of slides up because we recently had a community forum of combined DRESS and SJS patients. And the thing that came out across all patients globally was that post-discharge planning for them and their post-discharge care, it felt like they didn't really have any continuity. And this didn't matter if they were in the United States, Australia, South Africa. It was really across the board. And so it's really important to think about follow-up because there's different issues. For SJS/TN, the visual problems and the reproductive problems can continue to evolve after they leave hospital. For DRESS, they develop autoimmune sequelae and sometimes relapse 16 to 20% of the time, and this can occur greater than 5 years, we now know from some recent Japanese data. This is actually a recent tool that is going to be made into an app. It's by Anita Hansen from Liverpool in the UK, and it's really just a project they started to help the post-discharge patient with SJS navigate the complex pathways that they have to navigate and make sure that they know their culprit drugs, how they should be following to make sure they have the care they need, and this puts it all sort of in an organized construct. I just wanted to say a couple of things about immunotherapy. I focused mainly on small molecules today, but immunotherapy is really presenting now with scar-like illnesses, and as you know, it can occur years after the immunotherapy is started or even after the immunotherapy is finished. It may or may not be HLA restricted, and I think it's intriguing. I think that we often are underlooking the impact of a small molecule when drugs like ICI are started. And so drugs like sulfantibiotics and other antibiotics can actually cause scar in the setting of an ICI, and we think the chance of them doing it is higher than if you weren't on an ICI. And we've even seen, and there's some data coming out in publication to support, that drugs that don't normally cause scar, like fluoroquinolones and macrolides, may have a higher chance of causing a scar-like illness in association with immune checkpoint inhibitors. The other thing that's fascinating is the actual clinical spectrum and the latency can differ. And so these often have a longer latency, interestingly, when they're associated with ICI. And this is some preprint data that's going to be published soon from a junior faculty I'm mentoring who has found that really the latency and of SJS-like illness associated with ICI is altered in the presence of immune checkpoint inhibitors. We've actually seen other immunomodulatory drugs, that actually alter the presentation. So we recently had a case of HLA-B5801 restricted allopurinol dress, where the allopurinol was not initially realized as the culprit, but this woman had amyloid and myeloma and had started on a CD38 drug 3 weeks prior to dress occurring. And the allopurinol dress actually occurred 6 weeks later. So we think it was actually the allopurinol with the B5801 that was the cause of dress in this Vietnamese woman, and not her CD38 drug that was used for myeloma and amyloidosis. So just to close, what about the future? We have been biobanking for over a decade to try and get to the bottom of what actually the mechanisms associated with this. But I wanted to close by saying, much like the story we heard with Sweet's disease, that we can start to ascertain interesting and mechanistically relevant drug targets, treatment targets, by doing single cell studies. And this was a patient with Bactrim dress who actually was had a persistent rash, and basically they investigators did a biopsy and did single cell studies on the biopsy and showed that there was upregulation of several transcripts in the JAK-STAT pathway. And based on this, they actually treated with tofacitinib and had complete remission of the dress that had been active for over a year in relapse. And as mentioned, we've been biobanking. We started looking at blister fluid and skin in SJS because in early studies in TCR sequencing, we found that basically the T cells that were activated that were so prevalent in the blister fluid were infrequently represented in the peripheral blood, to the point it would be looking for a needle in a haystack. And then we continued with single cell studies. And in our last paper that was published a few months ago, we found that the model for this was clearly depicted by what we found in the skin and blister fluid. And these are these T cells that are sitting at the dermal epidermal junction are actually resident in the skin, expressing residency T cell markers. These are the ones that are actually proliferating in response to drug altered proteins, and it's the keratinocytes in the skin that are actually presenting the antigen to the T cells. And HLA class 1 is actually upregulated on these keratinocytes. So the keratinocytes that get activated by exposure to the drug. HLA is upregulated on the keratinocytes, and then they present the antigen to the T cells that eventually end up causing the local skin damage. Also, in this study, we showed that there's broad upregulation of TNF alpha on CD8, not just on CD8 T cells, also NK cells and macrophages. And we also saw upregulation of other pathways, which I'll show you. But Thierry Nordman did a beautiful study where he showed activation of multiple pathways in the interferon gamma suite and showed JAK-STAT upregulation, and actually did a small treatment study where he was able to show really quite rapid abortion of progression of SJS-TN with reepithelialization in lightning fast time in 4 days in actual patients. And so this leads to the topic that I'll close with that I think is quite exciting, that using advanced technologies, we can actually find new targets that are ripe for study. Some of these we can pull off the shelf, like TNF alpha antagonists have been known for a while to have some effect in SJSTN, but also JAK-STAT inhibitors, and then a number of other novel targets that target different cycles of anywhere from keratinocyte cell death to immune checkpoints to cytolytic pathways such as Fas ligand and granulysin. And so just in summary, I just like to close. As you all know, SCAR are rare and mainly drug-induced, especially in adults. Dermatologists play a crucial role. HLA does identify risk, but it's necessary but not sufficient, and it's geographically represented. So what we see in one population as an HLA risk factor will not necessarily be the prevalent risk factor in another, and this needs to be realized as a safety factor, particularly in terms of screening, but also for considerations in using HLA in the diagnostic arena. The risk for scars continued to be lifelong, and you've seen some of the data that we've done, functional data as well as skin testing data that supports that. We would never re-challenge patients at this point in time in terms of not really having the population to do that, but data from South Africa is very convincing in terms of the ability to abort reactions early on. The performance of testing that we can do depends on both drug and phenotype, and we use this a lot, sort of constructing pretest probability Bayesian type mechanisms. I think in the future we will have better tools to be able to use these in the clinic and to use these integrated approaches in the clinic to determine drug causality. The current treatment approaches, as I've shown you, really lack any level of evidence. They're mainly case reports, observational studies, very few randomized studies that have been open, but the mechanistic studies in these rare diseases really are proving to be very productive in identifying promising targets. And I'd just like to thank members of our Center for Drug Safety and Immunology at Vanderbilt and all of the team of researchers and patients and foundations, as well as funding sources that have made the work possible. So thanks for your attention, and I'm happy to answer any questions.
Thank you so much, Dr. Phillips. That was a fantastic talk, and hopefully everybody who wasn't familiar with Dr. Phillips now knows why I'm a big fan. Her work has formed the basis for much of what I and the residents do on the consult service on a daily basis. So any questions from our audience members? Yes, Dr. Dubé. I can also repeat your question here if you want to shout it. Oh, come on up. All right, Dr. Dubé is approaching the podium.
Hi, Dr. Phillips. Thanks so much for your leadership in this area and the wonderful talk. I guess the first question would be the discrepancy you're seeing between the HLA type, the sort of geographic sensitivity, the way you put it. What is your thought regarding that? Because in like human genetics broadly, in the setting of admixture, we think of the variants, the same variants being causal among different sort of ancestral groups. And your observation might suggest so either differences or differences in like viral exposure over time or some sort of interaction. And I'm wondering if you could speculate on why you think you're seeing this geographic sensitivity.
Yeah, so I mean that's exactly right. And so the I guess in our evolution and out of Africa and migration to different geographies that occurred under the influence of chronic prevalent infectious diseases, also new epidemics and pandemics. And so what's really very interesting about if you look at the world map of HLA, for instance, is you can see that there's all these different alleles represented, geographically in different regions. But the supertypes, the actual alleles that share peptide binding specificities, have been largely conserved. And so basically what we've seen is that there's been nuances in terms of, human and our coevolution with infectious diseases, which is not admittedly limited to HLA, but HLA has been the primary driver. And so that's why we see these different responses. Now, making things more complicated, I guess, in terms of the reaction to a drug is also implicitly influenced by those early reactions and those early responses and immune responses to infectious diseases. And so there's a lot of unanswered questions. If you moved to the United States when you were a young child, are you really, and you're exposed to a different form of Epstein-Barr virus? Are you at the same risk as if you were B1502 positive and you were born in, Taiwan and you were exposed to carbamazepine? I don't think we know these things, but we're hoping to get to, through a series of epitope discovery studies, which I didn't go into today, hoping to get to some of those so-called sentinel epitopes, which are largely virotopes and other infectious disease proteins that have driven these responses that may form the basis for the cross-reactive memory T cell responses that are driving these reactions to drugs.
Cool, thank you. And the second question I had was, what you've presented requires a lot of expertise, specialty lab work, et cetera. And I wonder if you can comment on your thoughts regarding sort of genetic sequencing and biobanks and health systems and how that could be implemented to sort of democratize this or spread this or help us take care of patients kind of more broadly in areas without the sort of expertise that your center offers.
Yeah, so I mean, I've thought a lot about this, and our center is just in the process of putting together, I guess, panels. So these are CLIA certified HLA tests that are done by PCR-based techniques. I think the tricky thing, and this is where I think it would be helpful to get a lot of feedback from clinicians, is putting together decision support in these panels. So if you had a hypersensitivity panel that included all of the risk alleles across different geographies, the decision support that would actually be helpful and interpretable, I think, is the hardest part of actually doing that. I think the actual typing has come down to a point where that can be accomplished quite easily. There's nuances, like if we tried to design a test, for cotrimoxazole that actually picked up all of the HLA alleles that were likely that had that shared binding pocket or shared peptide binding specificities. We could probably do that as well, but probably it's easier at this point to use existing technologies and then work on the decision support. And so I think the decision support is going to be crucial. I do think dermatologists clearly see patients after they've had the reaction. Clearly, we'd like less patients to be having these reactions, but the truth is that you see patients once they're already there. And so your ability to influence, prevention is unless you're prescribing the drugs, like goes down. And so I do think that diagnostics are going to be key in terms of using these tests with other tests. And the good thing about genetic tests is that we often run into the problem with patients with DRESS that they're on steroids. We can't do skin testing, we can't do ex vivo testing, but we can always do their genetic testing. So for common causes of DRESS like vancomycin, it's actually very helpful to know whether they're HLA A3201 positive or negative in the setting of multiple antibiotics, even if we can't do any other tests to help define the culprit drug.
Excellent. Thanks so much.
Thanks.
I see another question in the audience here. So the question I'll repeat is, do we have a clear sense of you're saying the degree, like the relative risk associated with these alleles and the development of severe cutaneous adverse reactions?
Yeah, and so that's an excellent question. And we've done, sort of modeling. So we know, we can actually determine, basically the positive predictive value it's usually a derived value because we often don't have a denominator, right? I mean, for vancomycin, we did that. We went through our EHR and we did a survival analysis, a time to event analysis of everyone that had started vancomycin. And then we looked at HLA-A3201 positive and negative individuals. We could see the ones with allele positive drop off. So we could actually derive that positive predictive value of 19% in the number needed to test to prevent one case, but it can be difficult if you don't have population-based studies to actually know what the risk is, because it depends, the number needed to test to prevent one case depends on the prevalence of disease, as well as the positive predictive value, as well as the allele prevalence in a population. So you have to consider all of those and actually looking at the risk to an individual. Or an individual in a specific area, like, is it worth doing this? Is it, what would the risk be of not, if I do an allele specific test, like you can get through GeneSight, like, B1502, what would be the chance of them developing a reaction if they don't have that in the United States as opposed to Singapore? Like those types of things. Those are the types of things, the reasons, the complexity of this is why it needs to be put into a decision support wording, because it is complicated, right? And the other thing that the FDA rightly has emphasized is that and globally, we cannot tell someone's genetics from the color of their skin or how they look phenotypically. So it's something that I think we have to just assume the US is very admixed and that we will be dealing with these influences. Ideally, it would be a case where we don't want to have to do large-scale population studies and expose multiple patients to the drug to be able to understand this. But that's something that, that lies in the mechanistic work ahead, I think.
I think we have time for one more question from Dr. Oldenburg here in the front.
Okay, I'll keep it really short. Great to see you. Great talk. We've been having some really complicated cases of multi-drug, maybe DRESS in patients that are on RIPE therapy, and then subsequently on second-line therapies for tuberculosis. And this is a little bit of a segue from Umber's question as well. But what do you recommend as an approach to help identify culprit medications in these patients? Certainly, we're very nervous about drug reintroduction, but
yeah.
Assays that you would recommend, or any things we should do? Should we be looking at patch testing? And I think this would be for very specific patients who have really complex courses. But what modalities should we combine? And then what CLIA labs, or where can we send some of these really tough patient samples?
So, I mean, I think things are like evolving with regards to RIPE and first-line anti-tuberculous drugs, and probably in the United States, the ability to pivot to other regimens probably influences some of that as well. But to date, there is no specific association with any of those drugs that we've been able to reproduce in the US. I think the rifampin story is evolving in South Africa, and it looks like there's a candidate HLA association there that we don't know that actually applies here, but we'd love to study that more. I think the patch testing and the ELISpot testing are probably the highest value tests in that regard, but they tend to be much better interestingly for rifamycins and versus the other first-line anti-tuberculous drugs. One thing that has been clear from the South African data, which I think is really important, is there appears to be extremely low cross-reactivity between rifampin and rifabutin, and rifabutin is a powerful anti-tuberculous drug. So I think one of the first things to do probably is to get them on first-line anti-tuberculous drugs that there's going to be limited cross-reactivity to, and rifabutin would be that drug in terms of sequentially reintroducing drugs in the United States. I think the other tests are really all research at this point. I mean, we have seen positive patch tests to rifampin, and DRESS is a more common phenotype with rifampin, but I think if you're dealing with something like SJS, then you're not going to be expecting to see positive results in either the in vitro ex vivo assays like ELISpot or LTT or skin testing. That's a problem. So it really does require pivoting to other drugs. You know, rifabutin can often be used in combination with other drugs that are, you know, outside of ripe as well. So I think we're still using a lot of clinical approaches in the US, to be honest, in terms of relying on cross-reactivity patterns and just trying not to delay therapy. Avoid approaches that lead to delayed anti-tuberculous therapy, basically. So it's not as satisfactory as I'd like, but the challenges that we're experiencing seem to be global challenges in terms of these assays and the drugs. So there's something about the drugs that make it harder to develop these for anti-TB drugs.
Thank you so much again, Dr. Phillips, and hopefully, you know, if other questions come up, thank you very much for kindly sharing your email address. Hopefully we don't make you regret it. But again, thank you so much, and wish we had more time, but everybody, a round of applause for Dr. Phillips, please. We'll leave the CME code up here for anybody that didn't get a chance to input it.
Thanks so much. Thanks for the invitation and the opportunity.
Thank you.
Yeah, that was all. Thank you.
Thanks.